Apologies, I will repeat some information that some of you already know because you've been with us along the last years. But for the one who are more new, we need to put things into perspective, a perspective both of time frame, but also a framework of work. So first, the relationship between WHO and RDI, we need to go back to the fact that up to 2018, WHO had not taken any action or ever mentioned rare diseases. So that was the first advocacy success, to have a statement from WHO Director General on Rare Disease Day. And we had a meeting right after that as RDI with Duran and Paloma and with some directors of WHO around the new Director General, where clearly there was an opening of collaboration, recognition of the issue. And already we were working with WHO in office in New York, Natam and Abbey, and with different permanent missions, as you know, and that's what Duran just reported. And rare disease were included in the Universal Health Coverage Political Declaration in September 2009. So, and then we signed the MoU, the Memorandum of Understanding between RDI and WHO in December 2019. So we had already had exchanges and groundwork, I would say, for 2 years to get there. But when you look at it, it's only 18 months to be to that point. So we were pretty happy with these developments. So what we will develop now in a moment is what are the long-term goal of this collaboration with WHO, but what is in for 2020. And these are the two elements which will be in, and I will detail that in a moment. In addition, there is activities which are not in the immediate objective of the collaboration, on which we are working in parallel, like the international classification of rare diseases and having a dialogue with the scientific department of WHO on codification and making the link also to human phenotype ontology and things like that, so that progressively there is an understanding that we need all these normative approach around rare diseases, which are essential to increase the knowledge from the national healthcare system after that. But also starting the work on essential diagnostic tools and essential medicines, and that is on our agenda today. The MoU Article 1 indicates the long-term objectives. So for you to know, we have a document with WHO, which has no status, it's just a document between us of discussions, which is covering the decade, the next 10 years. And then we have in the MoU objectives which are within the WHO general program from 2019 to 2023. So we're trying to show to WHO how rare diseases, and RDI in particular, can contribute to help WHO reach their goals. And in that way, they are helping us. And so that's why the framework is within the global program, the general program of work of WHO. And the specific objective over the 5 years for RDI and WHO is to increase awareness of rare disease and their visibility in the healthcare system. So awareness are things like Rare Disease Day and other activities of this type, or campaigns, information campaign. Visibility is very much codification, classification, etc. So all the normative aspects to increase the visibility in the healthcare system. The second objective is to strengthen the healthcare systems, including improving access to accurate diagnosis, prevention of comorbidity, and promotion of multidisciplinary holistic care. So I hope you're happy. It's words, they're only words, but I'm pretty happy that we have, as an objective over the 5 years, immediately that kind of language: multidisciplinary, holistic, focus on diagnostic, prevention of comorbidity. The third objective is improve access to affordable and quality treatment and care, and we know that's a big challenge. And objective 4 is to encourage member states to adopt strategies to address rare disease challenges at national level within an international policy framework. And obviously, that's not going to be the first thing that WHO is going to do. First, we need to put in place a certain number of milestones before we can get there to have WHO starting to engage member states, or at least letting us engage member states on their behalf. Next slide are the specific objectives. So as I mentioned at the beginning, for this year in 2020, we have 2 specific objectives. The first one is within the work of universal health coverage and healthcare system strengthening through the global networking of specialized expertise. And the language, the text which is in the Memorandum of Understanding says that WHO and RDI will collaborate to improve the diagnostic of healthcare, so the general objective that I mentioned before, with specifically a global network of multidiscipline specialized expert centers for rare diseases through a structured approach, grouping rare diseases by therapeutic area, so to be inclusive of all rare diseases, to leave no one behind. So you see the connection with what Joanne was just saying on SDGs and universal health coverage, leaving no one behind extra. So we have that kind of approach there. And specifically for this year and next year, RDI will prepare for WHO a need assessment study, so to propose the conceptual and methodological framework to create such a network with a strategy which is both bottom-up approach that promotes the identification and support of highly specialized multidisciplinary centers of expertise, and to connect the centers of expertise regionally and internationally into future WHO collaborative global networks for rare diseases. So that's what Matt Johnson will present more in a moment. The second objective that we have in this MOU is to work on the objective of data sharing to improve the recognition, we could say visibility, of rare diseases in the health systems. And to start with is to have an operational description of rare diseases and key figures about the prevalence or incidence of rare diseases. So that's what we will discuss also in a moment with Rath. So we're starting now, going from 2 years ago, 18 months ago, to just having a declaration from WHO, then engaging into legislation, the first legislation with soft legislation, but with UHC. Now the Memorandum of Understanding, so framework of work, and now we're starting the operational work. So now the vision, before giving the floor to Matt, the vision of this WHO collaborative network. Sorry, I need to move the window. The WHO collaborative global network for rare diseases, and I hope you appreciate that they are called like that. It's not me calling them like that. It's not Matt or Duran calling them like that. It's how WHO wanted to call them into the MOU with RDI, to call them WHO Collaborative Global Network for Rare Diseases. And the goal is to connect the major academic, healthcare and research organizations. So basically major hospital with research capacities and linked to a medical university. And where there exists already expertise on some rare diseases, multidisciplinary expertise, which maybe is not well structured to take care of people with rare diseases, but could be. So there is this expertise, these specialist capacities, which can be multidisciplinary within these healthcare research and academic centers, and to connect them at the regional level and at the global level. In that way, the initiative contributes from the perspective of WHO, but also for us, by the way we're approaching it, to implement the universal health coverage. It's one of the ways to provide access to diagnostic, to provide access to prevention of comorbidity and to the initial holistic care. And to strengthen healthcare systems. Why? Because the healthcare systems are able to respond better to the needs of their populations, in particular, the vulnerable populations affected with rare disease, diagnosed, misdiagnosed, or undiagnosed. Within the SDG Agenda 2030, the ambition of this global network is potentially to serve 2 billion people in the world. Okay, that's quite ambitious. What does it mean? It means that we're looking at the objective 2030 of SDGs and we say, okay, 10 years from now, how much people could benefit from that network? And our approach is to say we're going to look at the countries where there is already existing well-advanced facilities. There is the countries where it's less advanced, but where there is major cities which have the capacity with the big hospitals and medical university and research centers. And by connecting them, we could already provide a better access for 85 million people with rare disease in the world, which, if you take the prevalence of our diseases, means a wider population of 2 billion people. So it's not the world, but it's getting to the world progressively. And specifically, the goal of the network is to expedite and provide accurate diagnosis. So the angle of that strategy is diagnosis. Raise awareness, raise visibility in the healthcare system, diagnose more patients, and try not to misdiagnose and try to diagnose quickly. So reducing the time to diagnose, reducing the misdiagnose, and addressing the diagnostic odyssey so that it takes less than 1 year by 2030 to be between the time of the first contact with the doctor and the diagnostic. Second objective is to break down the traditional barriers in accessing care, often experienced by patients and their families through open, direct self-referral. And here you will see the link with some of our work with the Global Commission, right? Trying to not to wait that the healthcare system are reinforced and stronger, but that we can empower themselves, the patients and the primary care providers, to help refer the patients to the experts, so potentially to these hospital centers, to these hubs. And overall, all that with the ambition of providing holistic, affordable, quality, highly specialized healthcare, which obviously is an ambition, but the approach is from the beginning to try to aim for quality outcomes, for measurable health outcome for patients. And now I stop and give the floor to the video from Rüdiger Krech, who is the director of Universal Health Coverage at WHO and healthcare system. Davor will launch it.
Dear colleagues of the RDI community, I'm really sad that I cannot be with you today in person to validate trends in the future of rare disease and health policy. As you are designing potential future scenarios based on these trends, I'm humbly adding some thoughts. I was particularly pleased to see the analysis of the emerging trends that you have conducted. This gives a strong basis to build potential scenarios. I would complement such trends with those that will have an impact on the diagnosis and treatment of rare diseases. When it comes to new technologies, I would widen the view slightly to include innovation, for instance, in communications technologies, as these might have an impact on potential innovative networks and centers of excellence globally. You have shaped this foresight study very well. You have asked us to look 10 years ahead. What would we call a great step forward? Where do we want to be? Well, for my part, I would like to see a network of centers of excellence of rare diseases globally. These centers would cluster groups of rare diseases and bring together world-class experts in the diagnosis. They would be connected virtually with care centers around the world and stand by for acute advice during patient crisis, and be virtually present at the bedside. These experts would be partners of treating health personnel and counsel when it comes to the organization of care at home. Such centers would be top-notch research places when it comes to innovation in diagnostics and exploit ever shorter innovation cycles for diagnostics and treatments of rare diseases. They would be world-renowned training centers and offer twinning opportunities. They would be financed through international agreements of healthcare purchases. The health impact of these centers of excellence will be to reduce the time it takes to diagnose a rare disease, to improve the patient-centered care, and in the best of all scenarios, they would also decrease the number of patients with rare diseases, as some more might be found to be curable. Dear colleagues, in WHO we have a clear compass that orientates us conceptually and in prioritizing our work. It is the global program of work in which we seek to reach 1 billion more people that will benefit from universal health coverage, 1 billion more people being safe from emergencies, and 1 billion more people enjoying healthier lives. We are committed to leaving no one behind, and this includes obviously also people with rare diseases. This current GPW runs until 2023. It is guided by the Sustainable Development Goals and is an operationalization of these goals in a 5-year period. I'm sure that the scenarios and options that you are developing will be operational as well. To this end, you are looking at the PASL categories. Each of the categories is obviously important to consider in developing strategies that drive the implementation of the scenario you developed. For instance, the availability of certain medicines should not be a matter of charity, depending on the goodwill of a donor who could, if the wind changes, withdraw the commitment. Medicines for rare diseases have to be part of a transparent pricing system and included in prepayment mechanisms of health insurance. As we all know, this will require serious efforts by all partners, as the current practice is indeed intransparent and confidential. WHO has initiated a fair pricing dialogue with industry and partners, and thus makes the economic argument to provide needed medicines for everyone. But there is also scope in looking at the interdependency within these categories. Only if we can show the way to such a transparent pricing of medicines will the political argument of leaving no one behind become a realistic goal. Only if we link the societal and cultural shift towards universal health coverage with an ethical dimension that no one should die because of an inability to pay out of pocket for hugely expensive drugs, can we also make the case for rare diseases. I wish you fruitful deliberations, and I'm grateful that you consider WHO to be on your side.
Thank you. So that gives you a message from WHO on these aspects. With that, I would like to turn to Matt Johnson. Matt Johnson is new to you, to this audience, but not new to the topic. Matt is RDI, the new RDI Healthcare and Collaborative Global Network for Rare Diseases advisor. So he's working a certain number of days for us, I would say, during the year. But he brings with him a long experience in Europe on the European Reference Networks, and before that into the public service of the National Health Service of the United Kingdom, where he developed the specialized services for rare diseases, commissioning services. So Matt, the floor is yours.
Thanks, Yann. So I've prepared some slides which just to expand really on Yann's vision, the vision in the Memorandum of Understanding. When we think about a global network for rare diseases, we're thinking very much in the WHO terms, i.e. by 6 regions, and trying to think about how we connect those 6 regions, understand the needs of the 6 regions as well, because services in different countries in different parts of the world can be very different in their structures. We have some guiding principles that it's 1 global network, not 24 like we have in Europe. We have 1 global network for rare diseases which connect global hubs together, and that these hubs really are lighthouses for rare diseases, recognized in their own countries as leaders for healthcare, education, training and research. But for one of those hubs to be recognized and join, we need them to be assessed against some standards which we're going to develop, but also be endorsed by their member state. And when we have those hubs active at a global level, we think that we want to structure those activities under global programs of care, which are time limited, which maintains good participation because people elect to take part in something, maybe research or clinical guideline development for a specific cluster of rare diseases. But when we think about a hub, the role of a hub has two functions. There's one level where locally they should be there to improve access and coordination to high quality care and treatment and diagnosis, very much supporting the development of that health system's competency in rare diseases. And that's why we think the national endorsement is very important to strengthen the local health system's competencies in rare diseases. But when they come together and collaborate globally, we think that the first and foremost thing for these hubs to do is to improve access to quality care and treatment, i.e. the implementation of the universal health coverage, and removing those barriers locally for people, vulnerable and isolated populations, to come together. And obviously we think that education and training is an important thing for them to do as well. Also clinical guideline development, exchange of knowledge, data, and conduct research, but those are more secondary. We think that these, the three components really of these hubs should be that they should collaborate, that they should show how they use technology as an enabler to share knowledge and expertise and share their experiences and build the whole global network's competencies and capacities, but also to coordinate with multi-system rare diseases. Whilst we have fantastic experts in specialty areas, it's around the collaboration and coordination of those experts. So we think it's key that the hubs provide virtual healthcare and specialist advice, and they have a platform to enable timely diagnosis and to share data as well. But to build local continuity of care. With COVID, we know that now health systems need to be a lot more lighter on their feet and agile. So we think that their role in developing the competencies of rare diseases in their health system is key too. So the components we have come up with so far are, we believe that not only are these global hubs or in countries which don't have a fully fledged all singing, all dancing rare disease centre, but could specialise in one or two rare diseases. We think there probably should be an affiliated member function. But we think also that patient organisations are critical and should also be formal members. And as I said, that both those two elements come together, forming the global network under the 6 regions. When we think about a hub, we think about 4 key domain areas: national coverage and rare disease coverage in terms of expertise. Anna's talking later on, and we all now know the 98% of the population are affected by less than 400 rare diseases. So we think that, you know, one of these lighthouses probably covers the majority of those 400 conditions in their specialties in their hospital. But we need to ensure that they have good coordination and collaboration with other centres for those 1 in a million prevalence rare diseases, because they could be elsewhere in another part of the country or in a neighbouring country. So signposting collaboration is key to know and see. Resilience, systems resilience, I've mentioned already, and how they use technology as a way to move forward and enable good collaboration, coordination of care. We think that the recognition of the hubs in their own countries is important, because that strengthens the footprint of the global network. Because we build the local health system's competency, we are ensuring good coverage then of centres' geographical scope, and therefore we're improving people's access to universal health coverage. One of the feedback so far from RDI members was, whilst national endorsement is really important, when we say national endorsement, we think it should be threefold at the moment. Not just the national authority, Ministry of Health, but it should be done jointly with the National Patient Organisation, the National Alliance, the Ministry of Health, and the leading research body as well. So the national endorsement is key politically to recognise that expert centre as a global hub to come forward, but under a rare disease plan, because we think that that should be in that context. And globally, members of the network, as I said, patient organisations and those affiliated members for countries which don't have the full range of expertise because of population sizes. But a hub, should it be a single hub or should it be multi-centre? We think it probably could be either. We want it to have the flexibility in the scope of this, so we could have a virtual hub of 3 or 4 hospitals, maybe in Canada, coming together as one global hub for that, for Canada, as an example. I've talked here already about the primary aims. I won't review that again. But these programs of care, I think, is an interesting concept. We think they should be thematic in their grouping. There should be a clear action plan, time limited, but we want to create an interface with third sector partners. So therefore resources, whether it's with pharmaceutical organizations or whether it's with Microsoft or IT organizations, that there's a clear way that under a program of care that there's different opportunities globally to do different activities. So the chat's open. We really want to know, do you know of a hospital or a healthcare provider in your country who you think that, you know, our hospital would just be doing ECRD in Sweden, so in Gothenburg or the Karolinska, they would be a global hub. If you know of your centre is an expert, a lighthouse in rare diseases, put it in the chat, because we want to try and map that at the moment. We've been engaging, and I'll show you a timeline of the work which we'll carry on doing this year with RDI members. This is very much an at the moment. The vision of the global network is a sketch, and we're trying to breathe colour into this, breathe life into this from your perspectives based on your needs. So at the moment, we've started to identify from the feedback so far from the webinars we've done some key feedback, and we're using that to change how we do the components of the global network. So an example here, on the last webinar, we were told that national policy is really important to promote rare diseases and universal health coverage. So we want to include that as part of the endorsement. Endorsement should be within that framework. And therefore, for centres wanting to put forward, we're trying to move forward the situation locally, politically. I won't go into the details on here, but the slides will be available. I think it's important for you to see we're listening and we're changing the model as we go forward. I mentioned about patient members being key. So number one, we think that they should also have a national or international population they serve. They should be recognised as their competency as being advocates, and they should also be endorsed by their board to take part. So it's not one individual acting, it's the organisation taking part. And we think that there should be some standards and a way to manage entry in and out of the global network from the patient side as well. But patient organisations need to do something and be active within the network. So we've been very clear, and we want to be clear about the role. Whilst we all recognise patients are experts by experience, patient organisations, we think that the key role, because this is about improving access to quality care and diagnosis, is that the role in the global network is to support your vulnerable groups and isolated populations to be able to access care. So working with those global hubs within your country. Also to build capacity building and promote health literacy and be that bridge between network discussions and the community. So we've got a poll. Could we?
Hi, Matt. Yeah, I'm ready to run the poll.
Thank you. Shawalani, I get it.
You're getting there.
Yeah.
What should the key activities and functions of a global network for rare diseases be? Choose your top 3 priorities. Develop rare disease competencies in the national health systems. Make experts visible and signpost patients. Support the development of an official recognition for rare diseases. Experts offer acute advice and organization of care in patient crisis. Develop diagnosis tools and best practice. Collect data and benchmark outcomes of care. exploit advancement in technology and innovation, develop new best practice and innovation through knowledge sharing, offer training and education activities, support clinical research and activities. I'll give you guys a few minutes to think about your responses.
Thank you. So while you're giving those feedback, I'll carry on, and please give me the results when they're available, if that's okay.
Will do.
So in terms of the project, we need to, as Yann pointed out, the Memorandum of Understanding says that we need to come up with a needs assessment study, which outlines a conceptual model and the methodological framework of what a global network is and how centres can apply. So this project then is over 5 years. This year it's a discovery phase, which we do that needs study. Next year we do the methodological framework, which is the development phase. Then we'll use that methodology in the year 3 to do a call for applications, and we'll do the assessment, and those centres which come forward we'll then pilot as a global network in year 4. Are the results in?
Yes, the results are in.
Yeah, super.
Here we
So
go.
I'll just pause. Super. So obviously the highest one is to develop the national competency in terms of rare diseases. And the next one is around benchmarking outcomes of care. That's great. Great to see that that's moved quite high on the list, and supporting the official recognition of rare disease. So rare disease plans being part of the endorsement, I think would be part of how we achieve that. And education and training, where's that? So education and training scored less than I thought. That was quite interesting. On the previous calls we've had, we've been told that that's really a quite high importance. Research is quite low as well, which is quite consistent with what we've got so far. So we use this feedback, which has been really great. When we come up with, next year, when we start designing the methodological framework, we need to set standards for centres to meet to join the global network. We'll use those areas to be able to structure how we develop those standards, those operation criteria. So this year, the discovery phase, we're doing 3 activities. We're doing a literature review to identify the evidence base for networking. We're doing a needs study on a selection of reference cases to identify population needs. And we're doing semi-structured interviews of existing networks to be able to then gain insights of what works, what's the added value of the existing networks like EURORDIS or the ERNs or NIH, and see how they structure themselves and their characteristics and the services they provide and what the feedback from the community is. So the knowledge, the insights, the needs and the evidence will be used then to shape something called a concept model. And that will describe the what the network should do, and how the hub model will be structured. And then next year we'll take that concept model and we'll turn it into a more detailed framework. So this will be a bottom up. So instead of looking at a global network and networks which are in existence looking downwards and global needs, next year we'll be mapping the potential hubs, going to do on-site visits, seeing about their competencies based on the needs which we've identified in the needs study. How do they meet the holistic needs of those conditions, to see how ready those hubs are in participating in a global network. And of course, looking at the existing assessment processes which are in place and designing something around eligibility, application and support tools, but also the assessment process, criteria and standards. So that work will be done next year. This year, the output of this year will be 2 documents. The concept model, which will be the what the network will do, what the hubs will do, what the patient members will do, and the how. Who's the decision maker in the assessment process? What's the process for assessment? I mentioned a bit about needs. This should be we want to approach this through the needs of people with lived experience. So we want to do the survey this year of a number of selected reference cases on cluster of rare diseases, looking at function, health and disability using the WHO International Classification. So an example could be, we could identify Duchenne muscular dystrophy as a reference case for neuromuscular and movement related disorders, functions, and collaborate with the International Federation to survey their members to see how how needs are different in different parts of the world. We'll use that learning from the different reference cases from the survey to come up with a balanced scorecard, which will be used when we do visits next year to hospitals. So instead of saying, well, what expertise you have in your hospital, we want to see how they meet the holistic needs of people with under these different clusters. And lastly, we'll use that the visits to do a baseline competency of where the expertise is around the globe to be able to develop the assessment standards which will be used for application. I mentioned about looking at needs and clustering by function, disability and health. So this is the WHO classification. So we'll be looking for a reference case for each one of these clusters to be able to do a survey, and we'll be engaging with RDI members for that. Last slide. We have a number of webinars this year. So you can see here, the next thing we'll be doing is some focus groups based in the different geographical WHO regions of RDI members to identify needs, to test out some of these concepts and ideas around what a hub should do. Does that model work in China versus North America or Australia, etc. By August, we're looking to present the results of our literature review, and I think it might move to September, to be honest, and we hopefully share the results of our survey. October, we'll be looking at sharing the insights we've gained from the interviews and what the concept model will look like. And the final piece of work will be submitted to RDI in terms of November. So I think that's it.
Thank you, Matt. Thank you. That's really great. And it takes more than one time to really grasp on this presentation where there is so many important information and concepts and terminology. And so, but I can see from the chat that there is a lot of conversation going on and a lot of interest with concrete elements brought forward. Thank you very much. And without any further ado, because we are over time, I'm turning to Anna Rath, and we come back to you at the question time. So Anna Rath is Director of Orphanet, and you know Anna from previous meetings of RDI, when we had the meeting at the UN and also in Geneva, if I'm correct. In fact, why are we working with Anna on the topic that we'll discuss now? Is not only because of Orphanet and because of Anna herself, but because also Orphanet has been the secretariat to support a group of experts to work on the classification of rare diseases in the context of the revision of ICD-11 some years ago. And so all that is already somehow in the pipeline of WHO. So there is a strong rationale for RDI and Orphanet to come together when it comes to this topic of definition of rare disease. The floor is yours, Anna, to explain where we're coming from and the perspective on that. Thank you very much for being with us.
Yeah, thank you very much. Yann, can you hear me well? Yeah.
Yes, very well, very well.
Okay, so super. So I will share my slides, and I thank you very much, Duran and all the RDI colleagues. And tell me if you see the slides. Yes. Can you confirm you see the slides?
We do. We see the slides. Go ahead. It's perfect.
Perfect. Perfect. So yeah. So we, as Yann told before, we are working together from a while now on this matter of the definition and of the data that a global, common definition could allow us to gather. And we started working on this article that most of you maybe know, tried to estimate how many patients are out there in the world suffering from a rare disease. And to do that, we exploited the Orphanet database of epidemiological data, and we co-authored that together with EURORDIS, so with Yann, in order to give to make these figures talk and to give a perspective that is the one of this strategic agenda that RDI has. So we discovered some results by doing this exercise that is, I insisted on the word estimating because it comes from the literature and not from real world data, because we don't have a good data and precise codification of patients, enabling that, us to have this data. So out of this estimating prevalence and patient numbers work, we saw that the big majority of rare diseases are very rare, and that what you have here in green, that the vast majority of the people suffering from the rare diseases, so more than 28%, have one of the around 400 most prevalent rare diseases. What is happening with the animation? So it's not working. But as you see, the majority of rare diseases are very rare, and only 2% of all the patients have one of these 90% of rare diseases. So they are the most vulnerable population. If we set strategies, as Matt presented already, based on the more prevalent rare diseases, we still are managing a place, a home, to these most vulnerable patients that are really very scattered over the world. And I would like to say, is towards them that we need a global network, because the expertise for them is really very rare and is really scattered over the world. So we need to connect all these centers that are shaped for the most of the people, most prevalent rare diseases, in order to also tackle the problems of the most vulnerable people, in order to leave no one behind. But if we look at what happens in the world, we see that because of the vast majority of diseases are very rare, even the most, let's say, constrained definitions based on prevalence over the world cover the vast majority of diseases. So the list of disease is very overlapping in different parts of the world. But when it comes to patients, we see that the definitions based on prevalence that do not cover the most frequent rare diseases are not covering the majority of rare disease patients that are included in other prevalence definitions. So we have this definition problem that is that has two sides. One is the concept of what a disease is, and the other side is which is the can we have a common ground on the prevalence of rare diseases, and that is maybe not necessary. So as we will see. The thing is that we need anyway a standardized definition in order to have a common language, as we will see, and to know how many rare diseases are there. Because to make this publication, these estimations, and to count how many patients are suffering from rare diseases, we needed to start by defining what we would count. So we took an option for defining what a rare disease is, but this conceptual definition is maybe not shared in every places in the world and in all the settings. So there is this paper that we co-signed, so a big consortium of people signed for this call for have a conceptual definition of what a rare disease is. Because when you put together many terminologies, you have more than 10,000 rare disease related concepts or terms, but do we have more than 10,000 rare diseases in final? For that, we need to agree on concepts. So we face the problem, how to define a disorder. So a disorder, rare or not rare, it's a concept, it's a view of our minds that is really multidimensional. We can see the same object from different perspectives. And a disorder is also an object that we can isolate from something that is a continuum. And a lot of people try to define what a disease is without having succeeded, and that is from a long time now. But we need to take an option. So I like to bring this, let's say, optical or photographic metaphor that is that defining a disorder is to adopt first a point of view, so see one dimension, and then when you have chosen that dimension or this point of view, to make a focus on the level of interest for us. So you see here the same group of diseases, the same family of diseases from a clinical point of view. So you can say that classic congenital adrenal hyperplasia is a disease belonging to a group of congenital adrenal hyperplasia that are endocrine disorders and that have different clinical subtypes. From a clinical point of view, you can name these diseases that are reflecting the problems that a person is having. But if you adopt an etiological point of view, you will end by CYP21A2 mutation. And that could be, and that is the name of the disease from a genetic perspective, but it's not covering exactly the same clinical picture. So it's covering different parts of different persons. So the thing is that we do need, in order to have a common language and to talk each other and to share data and then to gather data and indicators for the future, is to define our point of view and our focus of interest. And it seems to me that our common interest is to leave no one behind. So for that, is the reason why we adopted for this paper and in our nomenclature a clinical definition, because we need to give a name to a disease that a patient, a person can hold, can name, and can, let's say, take for him or herself through all the pathway he needs or she needs to cover. A healthcare pathway by a real life pathway. So each person deserves a name for his or her rare disease. So we need this common language. But that is why we have adopted this clinical definition, because for us it's the more inclusive one, because it refers to what the patient has and what the doctors see, and that is independent of the knowledge we have on this disease, of if it is genetic or not, of the gene is known or not, is really the clinical picture that is homogeneous in at least 2 independent patients, so really covering even the most rare diseases. And our epidemiological study is based on that level. But having defined this level, we can still accommodate other points of view. For instance, the subtypes based on genes, or the groupings in order to aggregate data for comparability between countries. So it's really setting a common definition to have a common language, to make patients visible in order to take action. So really we need to generate data to measure the population burden, to have indicators in order to evaluate if the health policies are effective or not, etc., etc. And adopting this type of classification system allows to have a common thing that is cross sectors, that accommodates the needs of the point of view of the researcher, the geneticist, the carer, so the doctors, but also the public health by aggregating data that are coming from different sources. That is why we are delivering these ORFA codes that are not adopted everywhere in the world, maybe it's a dream, but that are also mapped to other terminologies in order to allow for interoperability across different parts of the world. So for us, a definition, independently of the definition of the prevalence concerns, we need before a consensus, because there is no universal definition. We need to agree on that. And for that, we need to reach a consensus on a concept behind what we call a rare disease. And then we need to recognize that could be different prevalence thresholds, because it depends on other considerations. But at least we will have an agreement between all the points of view in order to have this common language. So maybe I give you the floor, Yann, to comment on this.
Yes, thank you very much, Anna. So just to make the link to the members who were at the General Assembly of RDI yesterday, there were that same slides, and for the others to understand. So the way we're taking this activity for the year 2020 is that the objective is that by the end of the year, we will have a document adopted by, endorsed by WHO Secretariat that will provide this approach as Anna just presented. For that, we're putting together another group composed of some faculty experts of RDI. In Orphanet, in conjunction with WHO and RDI, will also identify experts around the classification to bring back into these discussions. And we will also engage all the members of the RDI Advocacy Committee. And will be also probably presented at some point to all members before final adoption. So that gives you a sense of where we're going with that work. Thank you. So now I yield back to Panama.
Okay, I will stop sharing.
Thank you very much again, Anna.